வெல்கம் டு டீ கடை பெஞ்ச். இன்னைக்கு ஒரு இன்ட்ரெஸ்டிங் கேஸ் ஸ்டடி பற்றி நம்ம டாக்டர் கூட டிஸ்கஸ் பண்ண போகிறோம். லெட்ஸ் மூவ் ஆன் டு த செஷன். குட் மார்னிங் சார்.
Good morning.
Sir, 64 years old male patient presented with drowsiness and altered sensorium. So his investigation revealed serum sodium around 112.
Okay.
So finally he was diagnosed to have SIADH. So how did you arrive the diagnosis, sir?
So generally, this patient was diagnosed to have serum sodium somewhere around 112 as soon as he reached ICU. So once we diagnose the patient to have hyponatremia, the first most important investigation we are supposed to order is serum osmolality. You know all very well that serum osmolality, or otherwise called serum concentration of ionic and non-ionic atoms, are absolutely dominated by serum sodium alone. So when you have low serum sodium, we expect low serum osmolality generally. So normal serum osmolality is somewhere around 275 to 295. So this patient has sodium level around 112. So naturally we expect low serum osmolality. So this patient also proved to be no more exception. So this patient also has serum osmolality around 251. So that means we are dealing with hyponatremia and low serum osmolality. One can ask, so is there something called serum osmolality to be done as a mandatory one? Yes. Even though we are very sure that all the hyponatremias can induce low serum osmolality, there are few conditions where in the presence of hyponatremia, your serum osmolality may be normal. For example, when you have hyperglycemia, or during the time of mannitol administration, or when you have triglyceride level more than 1750, I mean hypertriglyceridemia, when you have hyperproteinemia like multiple myeloma, for so many other conditions can produce hyponatremia in the presence of normal serum osmolality. So when somebody has hyponatremia but serum osmolality is normal, then you have to think of the causes what I have mentioned above. So these are called pseudo hyponatremia, or if I go into a detailed explanation, then that will be caused, that will be divided into isoosmotic hyponatremia, hyperosmotic hyponatremia, but I don't want to get into that. Yes, a very simple one, we could always say when you have hyponatremia, order serum osmolality, because serum osmolality 90% is determined by your serum sodium. So naturally you will have low serum osmolality. Very few conditions where serum osmolality may not be decreased, the condition I have stated above. So in this patient, serum osmolality is somewhere around 251. So first step was over. Then that means we are dealing with true hyponatremia. So in true hyponatremia, you have many causes, somewhere around 24 causes of hyponatremia is there. The next investigation would be urine osmolality. By doing urine osmolality, we are able to separate 3 causes from rest of the causes. What are the 3 causes? Yes. If you do urine osmolality, if urine osmolality is less than 100, so very rarely you will get urine osmolality less than 100. Most of the time we get urine osmolality more than 100 only. If you get urine osmolality less than 100, then you have to think of 3 important causes. One is psychogenic polydipsia, where especially schizophrenia people, they used to take water as much as 18 liters per day, which will dilute sodium. One. And second one is inappropriate IV fluid administration, especially hypotonic IV fluid, namely 5% X-dose or half normal saline. If you administer these IV fluid more than 3 to 4 liter or 5 liter without contribution of other IV fluid, then definitely it will cause dilutional hyponatremia. And third one, you will have beer potomania. So these are the 3 causes that can produce urine osmolality less than 100, but we rarely witness these causes clinically. So most of the time what happens, when you do urine osmolality, they will have urine osmolality more than 100. So more than 100 means you can exclude these 3 causes, what I told you earlier. So first step, order serum osmolality. So we expect serum osmolality must be lower. Then once you get lower serum osmolality, then order urine osmolality. Urine osmolality in most of the time it is more than 100. Less than 100 means I have stated the causes. Now this patient has low serum osmolality, then urine osmolality is more than 100. Once urine osmolality more than 100, I have told, so rest of the causes we have to explore. Then the next most important investigation is urine spot sodium. Now the purpose of urine spot sodium is, whenever you have hypovolemia, what happens? Our body will try to absorb water and sodium very avidly. So where you will get hypovolemia? So when you have enormous amount of sweating, when you have diarrhea, when you have severe vomiting. So whenever you have hypovolemia secondary to any cause, what happens? Kidney will try to absorb water and sodium. So what happens? You will have less amount of urine sodium. That is called urine spot sodium. So when you do urine spot sodium, what happens? If it is less than 40 milliequivalent, that means there is ongoing hypovolemia resulting in sodium absorption leading to low sodium in the urine, the otherwise called lower urine spot sodium. Then apart from this genuine hypovolemia, you have to think of another cause is false hypovolemia. What is false hypovolemia? You will have normal or increased total body water, but only in the blood vessel, or otherwise called intravascular compartment, you will have less amount of volume. So what happened? Our body thinks that, so normally our body will try to sense the intravascular volume rather than the total body volume. For example, all the organ failure, okay, cardiac failure or nephrotic syndrome or liver failure, where what will happen? Your total body water may be very high, but what happened? Because of extensive edema, your plasma present in the intravascular compartment or within the blood vessel would be very less. So our body will think that there is some true hypovolemia, so our body will try to absorb sodium. So in these patients, all the organ failure also, they also exhibit urine spot sodium less than 40. So when you have urine spot sodium less than 40, then you have to think of there is some ongoing hypovolemia, true hypovolemia or maybe false hypovolemia thanks to organ failure. Once urine spot sodium more than 40, then you can effectively rule out all kind of hypovolemia, whether it's true hypovolemia or false hypovolemia. So our patient has urine spot sodium is 160. So we are able to rule out all causes of true and false hypovolemia. So our patient presented with 112, serum osmolality is low, 251. So we are able to rule out pseudo hyponatremia. Then we did urine osmolality. Urine osmolality is more than 100. So we are able to rule out the three peculiar causes. Then we did urine spot sodium. Urine spot sodium is more than 40. So we were able to rule out both true hypovolemia and false hypovolemia. Then above urine spot sodium more than 40 means you have to think of two important endocrine disease. One is Addison disease and hypothyroidism. So we did serum cortisol which ruled out Addison disease. We did thyroid function, ruled out hypothyroidism. Two endocrine causes ruled out. If step by step when urine spot sodium more than 40, two important endocrine causes to be thought of, we ruled out. Then you should think of any possible administration of thiazide diuretics. He doesn't have any comorbid illness for which he is not on any medication. So he doesn't have any thiazide diuretics. So thiazide diuretic also ruled out. Then two important rest of the causes will be SIADH and cerebral salt wasting syndrome. Then to find out SIADH or to strengthen SIADH, you have to do serum uric acid. Uric acid would be very low. So patient's uric acid is only 1.7. That strengthens our finding of SIADH. So this is the way we finally arrived at the diagnosis of SIADH. So when you want to say SIADH, so there are 4 or 5 steps. First, serum osmolality should be low to ensure that we are dealing with true hyponatremia, point number 1. And second one, urine osmolality should be more than 100. So effectively ruled out 3 peculiar causes. Once urine osmolality is more than 300, then you have diverse causes, among which you have to differentiate with the help of urine spot sodium. If urine spot sodium is less than 40 means there is ongoing true or false hypovolemia. If it is more than 40, then you have 5 causes, 2 endocrine causes, addition and thyroid. Apart from that, you have thiazide diuretic, then you have SIADH and cerebral salt wasting syndrome. So this is the way we arrived at SIADH. So pathophysiology of SIADH little bit complex. So we will see in another session.
Sir, you beautifully explained about SIADH, sir. So then another one, sir. This patient also had aspiration pneumonia due to the state of drowsiness, sir.
Okay.
So he was given an injection Clindamycin.
Okay.
So tell me a few points about Clindamycin, sir.
Yeah. So basically, Clindamycin is I could say it is a very good drug, mainly active against gram-positive and anaerobic organisms. So Clindamycin doesn't act on the gram-negative organism. So whenever you suspect some gram-negative pathology, then you are not supposed to institute Clindamycin. Otherwise, if I would like to say about Clindamycin, I could say Clindamycin has excellent oral bioavailability. So almost 90 to 95% absorbed orally. So generally we used to give Clindamycin in couple of occasions. One, my professor used to say that Clindamycin for anaerobic organism above the diaphragm, metronidazole for anaerobic organism below the diaphragm. It's still applicable. So whenever patient has aspiration pneumonia, where gram-negative organism and anaerobic organism play a major role, so definitely Clindamycin is a part and parcel of therapy. That's why they have administered Clindamycin. Apart from that, any oral infection, definitely Clindamycin would be very useful, and it is very useful against MRSA, methicillin resistant Staphylococcus aureus. MRSA induced soft tissue infection. It is very useful. But generally, once it is administered, it is distributed everywhere other than the meninges. That's why it doesn't have any role in the meningitis. Otherwise, it is commonly given in lower respiratory tract infection, oral infection, even abdominal infection, even gynecological infection also. Dermatology is very commonly used for acne vulgaris in the form of topical solution or cream and so on. So Clindamycin, I could say it's a wonderful drug, but only one thing is it has to be used wisely and judiciously.
Okay, sir. Thank you. Thank you for your wonderful explanation, sir. So with this, we would like to wind up. In next session, we'll see about pathophysiology of SIADH. Thank you.
Thank you.